Healthcare in America, follow the money post. 8. Rural healthcare and consolidation. When the machine strains. So far, we've mapped who pays, where money flows, how a dollar moves, and explored administrative complexity and chronic disease. Now we see how these forces converge in rural America, where hospitals are small, margins are thin, and system complexity hits hardest. 1. Hospital closures. Over the past 2 decades, hundreds of rural hospitals have closed. Causes include low patient volumes, high uncompensated care, and increasing administrative burdens. When a local hospital closes, patients must travel farther for care, sometimes hundreds of miles for emergencies or maternity services. This is where the structural cost of complexity becomes tangible. Every layer of administration, insurance negotiation, and provider reimbursement adds to the financial pressure, threatening the survival of small facilities. 2. Consolidation and private equity. Many rural hospitals are acquired by larger health systems or private equity firms. Consolidation can bring resources and standardized care, but also centralized decision-making that prioritizes financial performance over local needs. Private equity ownership often emphasizes cost-cutting and profit margins, which can reduce staffing or eliminate underused services. The result: communities lose local services and residents experience less access, all while the total dollars flowing through the system continue to grow. 3. Limited access and telehealth. Telehealth promises expanded access, but it cannot replace all in-person care. Broadband limitations, staffing shortages, and technology adoption challenges reduce effectiveness in many rural areas. Even when care is available virtually, the real-world friction remains: long travel times, delayed treatment, and fragmented services. 4. Structural insight. Rural healthcare exposes the tension at the heart of the system. Complexity and consolidation allow the machine to operate efficiently at scale, but small, low-volume communities lack the buffer to absorb costs and friction. High spending doesn't guarantee access. In fact, it can coincide with service loss. The system is not uniformly broken. It is stressed where scale, demand, and resources collide. With rural pressures laid bare, the next step is to examine incentives across the system. Who benefits from complexity, chronic disease, and consolidation? This sets up the final discussion on reform principles, where we start talking about solutions grounded in structure rather than ideology.